Hello, I'm Rosemary Thomas-Mohtat, and I'm one of the POCUS faculty at Children's National. It is my pleasure to speak to you about lung POCUS. Today, we're going to discuss technical aspects of lung scanning, the how. We will interpret artifacts to understand what is normal, differentiate when images are not normal, such as in pulmonary edema, pneumothorax, pneumonia, and pleural effusion. The thing about lung ultrasound is that it's technically easy to perform, but the interpretation is trickier because there are so many terms associated with it. So which probe do we use? The answer is, it sort of depends on what you're looking for, but the answer is you can use any probe. The linear probe, which is the higher frequency probe, is better for superficial pathology such as pneumothorax. The phased array probe, which is lower frequency, has more penetration, is better for pleural effusion and pneumonia. The curvilinear probe and microconvex is in the middle. Next, we need to think about where to scan. That also depends on what you're looking for. Imagine this patient is supine. You look in the anterior chest for air, and you look at the basis for fluid, such as effusion or pneumothorax. There are so many protocols on how to scan the lungs, but I want to highlight two legends of lung POCUS that you may have heard about. The first is Lichtenstein and the blue protocol. He uses the hands to help visualize where to put the probe. There are 2 points on the anterior chest and 1 point in the posterior axillary line. And between these 6 points bilaterally, he found a 90% accuracy in getting a singular diagnosis. The second is Volpicelli, who developed this protocol with an international consensus. They divided the chest into these 4 zones, 2 in the anterior chest and 2 in the axillary line. So bilaterally, between these 8 zones, there is good coverage of the lung. I like to scan 6 zones on each side of the chest. So 1, 2 on the anterior chest bilaterally. You can see that the second position on the left chest is more laterally placed to get away from the heart on that side. Then 3, 4 in the axillary line bilaterally. And lastly, 5, 6 on the posterior chest. So are we ready? Let's go. Let's orient ourselves to start. We're using a linear probe. On the surface is the chest wall. We see the ribs with the shadowing. The bones absorb significant ultrasound waves, so they shadow. And the pleural line, which is the hyperechoic shimmering line moving back and forth with breaths. You might have heard that air is the enemy of ultrasound. It obscures what is underneath, but it creates useful artifacts. You learn more about these terms here than anywhere else in POCUS. So what is an artifact? It is defined as either a subject made by a human being of cultural or historical interest, such as gold and silver artifacts, or it's something observed in a scientific investigation or experiment that is not naturally present but occurs as a result of the preparative or investigative procedure. The first of these is the mirror artifact, which is a normal finding. This is seen when there is a highly reflective surface, like the diaphragm, in the path of the beam. The ultrasound beam comes down, hits this reflector, and most of it goes back to the machine. But some of it is reflected somewhere else, and then it returns to the machine. Because it took longer for the ultrasound beam to return to the machine, It thinks that it represents a point further away from the body. So for every true point in the body, a false point is generated across the reflector. So when the lung is aerated, a symmetrical image of the liver or spleen is generated on the opposite side of the diaphragm. If there is something space occupying, such as hemothorax or pneumothorax, then you will not be able to see the mirroring effect. The mirror effect also creates a reflection. You see the chest wall on top, then the shimmering pleural line, which is very reflective. So below the pleural line, you see the reflection of the chest wall. This artifact in normal lungs is called reflection. That causes A lines. These are horizontal lines parallel to the chest surface, equidistant from each other, that represents aerated lung. Contrast that with B lines as we continue to learn our lung alphabet. B lines are vertical lines that originate in the pleural surface and extend to the end of the screen. They obliterate A lines. They mean that there is some fluid in the lungs. B lines exist on a continuum. On the left is fully aerated lung without B lines. As air is replaced by fluid, there are more and more B lines as you move to the right. There are nuances to the visual appearance of B lines, which help differentiate between interstitial processes versus cardiogenic pulmonary edema, but that is beyond the scope of this talk. To be positive for pulmonary edema, you need to have at least 3 B lines in your field in more than 2 regions, and they need to be present bilaterally. So normal lungs have 2 features which are very helpful. First, we see the pleural line sliding back and forth with breaths. You can imagine there are ants marching along this line. And second, you see the A lines. Together, they indicate aerated lungs. So let's take a look at this patient. What do you see? There is no sliding. There are no B lines. This patient has a pneumothorax. And if you're unsure, we have an additional tool you can use to determine if there's a pneumothorax. And that is M mode. It is the 3rd alphabet letter that we're learning today. So M stands for motion. All machines have this feature. You just have to locate it. And what that does is it drops a line at the point where you are holding the probe and generates this tracing. On the top, you see the chest wall, which is not moving and appears striated. Next, you see the pleural line, which is shimmery. And then you see the aerated lung underneath. We call that a sandy beach or a seashore. Contrast that with the M mode of a pneumothorax, and you see a more striated appearance below the pleural line. We call this the barcode or stratosphere sign. Imagine it is more stratified than it's not. So we've talked about lung sliding, A and B lines, M mode. We have 2 more concepts to cover in regards to pneumothorax. The next is called lung point. And what we're seeing here is the edge of the pneumothorax. It's the point where the aerated lung adheres to the chest wall again. So on the left, you don't see movement, and on the right, you see a shimmering lung. You can see the sliding and not sliding areas, especially when you use M mode. You'll see the alternating barcodes and sandy beaches as the edge of the pneumothorax meets the aerated lung in the area where you dropped your M mode line. And finally, the last concept is called lung pulse. In M mode, you see this regular signal pattern on the pleural line. This is also an artifact of the patient's pulse or heartbeat being transmitted through air-filled lungs. If you see a lung pulse, that means that lung is aerated. So to put it all together, you're asking yourself the following questions when evaluating for pneumothorax. Is there lung sliding? No. Are there B-lines? No. Is there a lung point or the edge of the pneumothorax? Yes. And finally, is there a lung pulse? No. Then you have found your pneumothorax. So let's look at some cases. This is an 18-year-old male with asthma presenting with right-sided chest pain while playing sports. You see the positive radiology sign showing a small to moderate right apical pneumothorax. When you put the probe on the patient, you see this on the asymptomatic side. To remember the algorithm, you're asking yourself, is there lung sliding? Are there B-lines? Is there a lung point? What about a lung pulse? On M mode, yes, there is a rhythmic repeating pattern of the heart through aerated lung. I'd say there's a sandy beach too, and to support your conclusion that there isn't a pneumothorax on this side. Now let's look at the symptomatic side. Ask yourself again, is there lung sliding? There, yes. There, no. Are there B-lines? There, yes. There, no. Is there a lung point? Yes, right under those ribs is where there is the meeting of the aerated and unaerated lung. Is there a lung pulse? Let's look at M mode. No, I don't think there's a lung pulse. Do you think this is barcode or sandy beach? My vote would be barcode. It's often helpful to look at the two sides together, and now you can definitely appreciate that in fact the right side is barcode, consistent with your diagnosis of pneumothorax. So let's talk about what can cause a false positive for a pneumothorax. Basically, anything that causes the two pleural sides to not slide well. What can that be? Apnea, right mainstem intubation, which causes a false positive for a left pneumothorax, pleural scarring or pleurodesis, pulmonary fibrosis or pulmonary contusions. And what causes a false negative? Basically, looking where the pneumothorax isn't. The difference between lung versus fast is that lung, you're only seeing what's directly under your probe as opposed to communicating something that's somewhere else in the chest. So that was a lot to digest. We're going to switch gears to talk about another diagnosis. You have a patient with sickle cell disease presenting with fever and cough. You see the evident left upper lobe pneumonia, and this is diagnosed as acute chest. So what about POCUS for diagnosing pneumonia? There are 5 new terms that you need to become familiar with. The first is the shred sign, i.e. the lung margin is shredded, appears tissue-like, less filled with air. The normal lung artifact of A lines are missing. This tissue-like appearance must be present to diagnose consolidation by ultrasound. The second requirement is bronchograms, of which there are 2 types. The first is fluid bronchograms. They are anechoic, tubular, fluid-filled structures without shadowing. They do not shadow. That represents the small airways with fluid within. The second bronchograms are called air bronchograms, and they appear as hyperechoic lines with posterior artifacts or dirty shadows, and that's air surrounded by consolidated alveoli. Looking at this image, you might ask yourself, what am I looking at? Is that the liver? It's a tissue-like structure, but this is actually in the chest. So the third term for associated with pneumonia is hepatization of the lung. You can see fluid bronchograms. If you were wondering if these were blood vessels, you could put color flow over it and you would not see any blood flow within these tubular structures. If you were still not sure if your student was confused, so you asked them to see more clips, you see the liver to the right of the screen with the diaphragm over the top of it. And then as you sweep laterally and superiorly, you see this tissue-like structure that looks like the liver above the diaphragm, and that's the pneumonia. The last term is the spine sign. Remember back to the mirror artifact? The liver was reflected by the diaphragm into the chest, and the spine ended at the diaphragm. Now we've lost the mirror artifact because there is something space occupying above the diaphragm. So we are able to see the spine, therefore the term spine sign. This patient has a left lower lobe pneumonia because of the tissue-like structure and the fluid bronchograms. So to recap, pneumonia is diagnosed by the presence of air and fluid bronchograms, tissue-like echotexture in the lung, either small with a shred sign or larger with hepatization, and often with an accompanying spine sign. Now we have a patient with history of congenital heart disease who presents in respiratory distress. This is his chest x-ray. You can appreciate the density in the right chest for the pleural effusion. And this is his ultrasound. In the right side, in the mid-axillary line, you can see the diaphragm on the measurement side of the clip. These eel-like appendages are the collapsed lung. Why do you see the lung? Usually we don't, right? It's because of the altered balance of the air to fluid content compared to normal. There is much less air and more cellularity. Ultimately, 350 cc's of fluid was drained from this right-sided pleural effusion. Here we have another patient with history of osteosarcoma with lung metastasis presenting with tachypnea. In the ultrasound, you can appreciate the right pleural effusion and associated collapse of the right lower lobe, right middle lobe with air bronchograms or maybe B-lines. This patient ultimately drained 1.7 liters out of this side of the chest. And finally, to appreciate the spectrum of illness, we have this patient. You're in the right mid-axillary line. You see the liver below the diaphragm, and in the chest cavity, you see a complex, septated fluid collection with debris concerning for pus. This is an example of an empyema. So the lung is full of new and different POCUS concepts. It's all about the artifacts. But here's the takeaway. To diagnose pulmonary edema, you need to ask yourself, are there more than 3 B lines per field in more than 2 regions present bilaterally? For pleural effusion, you're asking, is there a spine sign? For pneumothorax, you're asking, is there lung sliding? No. Are there B lines? No. Is there a lung pulse? No. Is there a lung point? Yes, you have pneumothorax. For pneumonia, you're asking, is there a tissue-like structure above the diaphragm? Are there air and fluid bronchograms? And that's it. Let's take a deep breath and answer any questions during our scan sessions. Thank you so much.